My question has to do with basically the nature of the trials, and also whether or not the therapy is eventually planned to be a one-time therapy. Normally, I presume these are phase 1 trials. Normally, phase 1 trials are designed to find a proper dosage, but I'm gathering from what you're saying that in this case, this may be an attempt to determine whether or not the modified CAR T cells will stick around long enough to continue to do the job. Is that basically what part of the goal is for these trials? And also, is it hope that eventually there will just be one of these $500,000 therapies necessary to treat a patient?
Well, I think that of the at least 64 active CAR T cell trials that I see here for a variety of diseases, when I go on clinicaltrials.org, clinicaltrials.gov, they're questioning most everything. Single dose, more than one dose, different doses of cells in patient, different lymphodepletion strategies, in essence, different chemotherapy. There's not a question that I think is too small for us to consider. And I think that the cost of these trials and interventions, when they actually become available for outside of a clinical trial, envisioning that world so it's not $500,000 a dose is not hard to see. If you only do it once and you're comparing it to a myeloma patient who may get 10 years of therapy, well, clearly a one-time $500,000 charge is cost savings. But again, the idea of a $500,000 one-time treatment is not real exciting to anyone who's bought a copy of Quicken online. So I think we're all looking for single treatments that are going to be even less expensive, and things that we just talked about, having essentially a bank of CAR T cells available for specific tumors, would certainly be much less than taking personalizing or genetically engineering every patient's T cells. That would be much less expensive, and that's clearly where the field is going, or at least experimenting, but its effectiveness is unknown.
Thank you.
Gary, I think we can go on to a long list of questions that we have received via email.
All right, and that's exactly what we'll do. Okay, Doctor, let's go down the list. We've got a number of them here, and the first of which is somebody would like to understand, and this is really specific to them, and we might as well start off with it then. I think it's the only one this way. I'd like to understand what the increase in light change has to do with my myeloma. I have gone from a low 3-digit number to a high 4-digit number.
So I think that light chains and monoclonal proteins are really the protein products of myeloma cells, and we use them as an indirect measure of the number of myeloma cells in the patient. So if a particular patient's myeloma makes a set of light chain, or a proportion of light chains, and that amount of light chains in the blood changes, you'd expect that there'd be an increase in the number of myeloma cells in that patient, and therefore you'd conclude that the patient's myeloma is not in good control. And that's a dangerous spot, because when the patient's myeloma is not in control, they're at increased risk for fractures, anemia, and kidney failure, and those are all bad things. So I think an increase in your light chain suggests your myeloma is not in control, and we need to do some different therapy to get it back under control.
Okay, well, thank you for that. I'm sure she, or whoever that was, appreciates that. The next question is, are there any contraindications to this therapy, which is the one that you're talking about, CAR-T cells, or any drug interactions that you suspect could occur and one should be aware of?
So the things I think about are the contraindications are that if you have a CAR-T trial towards a particular target and the patient's myeloma, or at least the predominant clone, does not express that target, well, that would be something that you and I would be unexcited about. So that would be a contraindication to therapy because you'd expect it wouldn't work. As far as drug interactions, if you thought about it for a second, you can think, well, if we have a patient is taking medications that prevent their white cells from expanding, that essentially are immunosuppressants. And this comes about is if a patient is taking immunosuppressants to decrease their risk or decrease the manifestations of graft versus host disease, those often are immunosuppressants, and you don't want immunosuppressants when you give a CAR T-cell therapy. You want the CAR T-cells to be able to expand whenever they see the target. And if you're taking medications like Prograf or Cytoxin or Cellcept or any of a variety of drugs that are immunosuppressive, we theorize, although we don't know, that might make the CAR T-cells less likely to expand and therefore be less effective.
Well, thank you. How long would it take for this therapy to be administered, and in what form? Injections or oral? Would you talk a little about the dosage in which this would be effective?
So basically you need to get a certain amount of T cells from the patient. You need to genetically modify them, and then you need to expand them. Some patients don't have a lot of T cells. Older patients have more difficulty having them be successfully genetically modified and expanded, and that's an issue for patients where the average age of diagnosis is 70. The T cells that are genetically modified, we don't know exactly what dose to give, and we don't even know if it matters, because if they're going to expand, well, you're essentially giving a drug that increases in dose whenever it sees a target. So we don't even know if the initial cell dose is important, but certainly the T cells are infused, pretty rapidly through an IV line, and then a proportion of them go from their bloodstream into their bone marrow, and usually that's a target-rich environment.
Okay. The next one is pretty important as well. What is the timeline that you are looking for this therapy to be practically being administered to patients as a treatment?
So I imagine, for our clinical trial, we're looking to have this start up in the summer of 2016. But I think this question is really, when do you think this stuff is going to get FDA approved to do in any old cancer center? And I think it's a number of years away to be able to find an intervention that's both safe, reliable, and I think we're a number of years away from FDA approval in myeloma.
The number being 2, 5, 10?
I wish I had some sort of granularity on that, and I don't. This is a rapidly changing field where 5 years ago we weren't talking about this in myeloma, and certainly weren't talking about it occurring for autologous CAR T cells, potentially allogeneic, and all this is new and a rapidly changing field.
Okay, and obviously at Ohio State, but are there other centers that will also be able to have access to this treatment?
Certainly there are other centers doing it now, right? University of Pennsylvania, Dana-Farber, the NCI, National Cancer Institute, are doing these trials that have eligibility in myeloma. I know of other trials that are going to be opening up kind of across the world in London, France, and other spots in the U.S. So
for your CS1 trials?
The CS1 trial for myeloma is likely to start out at Ohio State, and probably won't be at other centers.
And then after what length of this therapy do you expect to see improvements in a patient's condition?
Well, the expansion of these CAR T cells usually occurs in most diseases in the first 2 weeks. So we certainly want to see a response right around 2 to 4 weeks after the initial infusion. And if we don't see a response in 4 weeks, you'd think that their likelihood of response is very low.
Okay. One of the papers on this technology mentions that treatment of patients with CAR T cells can cause cytokine storms, which in the setting of allogeneic transplant may induce graft versus host disease. Could you please explain what cytokine storm is and what in the CAR T cell triggers this reaction?
So every time that you infuse these CAR T cells into a patient in the proper environment, in a target-rich environment, these T cells expand. They see a target, and where there was one T cell seeing a target, then there's two. And where two cells see a target, then there's four. And you can imagine with that type of mathematics, it's not long for your 500,000 genetically modified CAR T cells to quickly turn into 5 million and 5 billion T cells. Well, as this happens, T cells that are in such a target-rich environment, these are cells that, by their nature, when they're surrounded by what they think of as foreign, become aggravated. And their job in general is to kill all the foreign cells, and they are now genetically modified to see the patient's myeloma cells as foreign, or the patient's cancer cells as foreign thus far. And when this happened in the past, a lot of aggravated CAR T cells being rapidly produced, some of the things that they use, these T cells, to kill the cells around them are called cytokines. And so they tend to leak these cytokines into the marrow and into the blood. But with such a rapid expansion, these cytokines or chemicals leak into the blood and can cause the patient to be incredibly sick. And this can occur with an allergic reaction. This can occur in a number of spots where you have all these particular type of chemicals shoot up in the blood. And these patients can become incredibly sick, develop what looks to be a pneumonia, dialysis may be required due to kidney failure, they can lose all their blood pressure and require ICU admissions. These patients are sick. And when these line of testing and these CAR T cells trials were at the beginning, this was pretty mysterious. But it wasn't long before people figured out what was going on, and in parallel, there's a group of drugs that are anti-cytokine therapies. They target these chemicals specifically. Interleukin-6 is a target for a lot of these drugs, and when they lower interleukin-6 levels, after giving these drugs, patients get quickly better. So what we hope to do is monitor patients for these cytokine storms, and if they occur, to have this supportive therapy administered early, before patients become sick. this will allow the CAR T cells to still expand and do their job, but not have such rapid expansion that it puts the patient vulnerable and causes them to be sick.
Very interesting. Thank you so much. Does the risk of becoming a non-secretor increase as patients survive longer? And how should this affect monitoring, the labs, PET scans, etc.?
So being a non-secretor, some patients at diagnosis are non-secretors, and some patients do become non-secretors, but in my experience, it's the minority of patients. And following non-secretory myeloma is difficult because no one particularly wants to do a bone marrow biopsy every clinic visit. And a bone marrow biopsy in myeloma only tells you what's going on that side of your pelvic bone, which is not necessarily indicative of what's going on in the entire patient. Sometimes patients with myeloma bone disease who are non-secretors, you can follow via CAT scan, MRIs, and PET scans, but a lot of times PET scans are not particularly helpful here either because it only detects the most aggressive myeloma, and somewhere between 20 and 40% of patients with myeloma bone disease have PET-negative disease. So following non-secretory myeloma is a challenge, especially since many clinicians often follow myeloma patients simply by blood tests. I think the biggest...
When you said the PET scans, that's news to me, that 20% of bone disease is not identified through a PET scan. So how is it identified?
So you can see it on CAT scan, you can see it on X-ray. X-ray obviously is probably the most insensitive way because it requires cortical destruction. The outer part of the bone has to be destroyed before it shows up on X-ray. Cross-sectional imaging like CTs and MRIs are much more sensitive. And PET scan can be even more sensitive than CTs and MRIs, but it can occasionally be less sensitive because it requires that the myeloma cells that are non-secretory are metabolically active enough to pick up the dye used in the PET scan. So non-secretory disease generally requires that patients be followed reliably by either the same physician or excellent documentation to state, hey, listen, this patient doesn't secrete, so don't bother doing the myeloma labs all that often or depending on them. Make sure you depend on cross-sectional imaging like CTs and MRIs and occasionally PET scans to follow their disease, as that's most likely to be accurate.
Now, all the people who are not non-secretors, then the PET scan works for them? It's just these non-secretors where it's an issue?
No, it can be, PET scans may be insensitive in both secretory and non-secretory disease. PET scans are insensitive in patients whose myeloma doesn't pick up the dye quickly, and that may not have anything to do with whether they're secretory or non-secretory disease.
Well, it's news to me, but that's interesting. Thanks. I appreciate that. Got one last question, and that is that a person says that they want to pose a question to you that they feel is off subject, and they think it's off subject because there's a fine line between immunity and autoimmunity. Dr. Hofmeister mentioned on previous Cure Talk call that he had observed that myeloma patients with autoimmune disease experience an increase to their autoimmunity while their myeloma is improving with treatment. Could you expand upon that observation as well as any other learnings about myeloma and autoimmune disease?
Sure. So autoimmune diseases are well known. Rheumatoid arthritis, psoriasis, lupus, connective tissue diseases. All these are when your body is attacking itself, really. And that doesn't necessarily mean that these patients who have an autoimmune disease are protected against developing myeloma. In fact, they can. But myeloma in and of itself is very immunosuppressive. So if your myeloma flares, usually the patient's autoimmune disease simmers down. So we are often fond to say that having active rheumatoid arthritis and active myeloma cannot happen at the same time in the same patient. And what we have seen is patients who have an autoimmune disease, or maybe they don't, and they develop myeloma, and then after treatment, their myeloma goes into a deep remission, and then their autoimmune disease flares. And then as their myeloma becomes more active, their autoimmune disease simmers down. And sometimes you get this back and forth. This doesn't occur that often, right?
But it's a hard place.
Right. And, it requires somebody have an autoimmune disease and myeloma, but they do occur in the same patient population, but usually not in the same population at the same time.
Okay. That's quite interesting. Well, those were all of the questions that we had for you, Doctor, and as always, you have been a wealth of knowledge, and we really appreciate all the things that you're doing, especially with this CAR T-cell study, because it looks so good, and your results to date have been very good. Priya, do you have anybody else online that would like to ask a question, or would you like to?
Thank you so much, Gary. I think we are almost come to the end of the hour. Dr. Hofmeister, it was great listening to you. Thank you so very much for taken time out to share this information about the new therapy with our audience. Gary, Pat, and Jack, I usually thank you so much for your participation. And today's talk and its transcript will be made available on Pure Talk's website. Please visit www.puretalks.com for details on our upcoming talks. Thank you, everyone.
Thank you, Priya. Thank you, Doctor.
Priya.
Yes, thank you. Nice to talk with everybody.
Thank you. Bye-bye.